Okay, Assalamu alaikum wa rahmatullahi wa barakatuh. Ladies and gentlemen, good evening. It's a pleasure and honor for me to be really moderating this first virtual meeting of the heart failure group of the American Society this year. And I'm really joined by a very distinguished speaker that will give us talks that all of us will learn from. And I'm really looking forward to the talks and the discussion that follows that. Unfortunately, there's a slight change in the program. Dr. Fahd Sindi, due to an unexpected, unforeseen emergency, they just texted us about half an hour ago and he cannot join us. So we still have a great two talks that will go one, then discussion, then second one and further discussion. So I can write your questions in the chat box. Will be forward to us and discuss. And during the discussion, you can speak directly. So our first speaker is Dr. Shahrukh Hashmani. He's assistant clinical professor, consulting cardiologist, heart failure specialist in Cleveland Clinic, Abu Dhabi. He's very kindly really agreed to give a talk in a also relatively short notice, and I'm really grateful to him and give that. His talk is titled The Evidence Behind Acute Management of Decompensated Heart Failure. Floor is yours, Dr. Hashmani.
Thank you, Dr. Harari and the team from the Emirates Cardiac Society Heart Failure Working Group. I hope I am being heard clearly. All right, so the topic of my presentation is on the evidence behind the management of acute decompensated heart failure. I'm a heart failure cardiologist working at Cleveland Clinic, Abu Dhabi, and none of the disclosures relevant to the talk. So as we know that the acute decompensation with heart failure is a sentinel event that signals worse prognosis. At the same time, it provides key opportunities to redirect the disease trajectory pathway. The management involves basically establishment of optimal volume status as a major goal, and to treat whatever the residual congestion that requires further consideration of intervention before and after discharge, so as to reduce the risk of pre-hospitalization and death. At the same time, the purpose is that we should continue the guideline-directed medical therapy during the hospitalization, as this has clearly shown to reduce the risk of post-discharge death and readmissions compared to those patients whose medications are discontinued. Our recent guidelines on the heart failure do recommend that we need to identify what are the precipitants for the hospitalization with acute decompensation, with coronary artery disease being one of the most common factors. In addition, we have the non-compliance to medication or medication that may predispose to increased risk of heart failure, such as the use of NSAIDs. As we know that readmissions with hospitalizations carry increased cost as well as increase the risk of mortality. So readmission after the first phase carries a mortality of about 12% at 1 month, and this progresses to about 5% at 5 years. Hence, the goal should be to prevent as much as possible the risk for readmissions. And how it can be achieved, there are 4 goals of therapy. Number 1 is to achieve thorough decongestion without the evidence of any residual volume overload, and to maintain adequate organ perfusion. Number 2 is to maintain or restart guideline-directed therapies, which are known to improve the prognosis and prevent hospitalization. We have to identify precipitants and treat comorbidities and avoid the potential triggerers. And the last but not the least is the post-discharge care, which will be discussed in the subsequent presentation. So to achieve, why it's important? Well, to achieve, because the thing is that the persistent congestion and outcomes are associated with acute heart failure are very dismal. Patients who have one or at least more signs and symptoms of congestion or elevated wedge pressure pre-discharge or those patients who have elevated NT-proBNP levels. These are the patients who tend to manifest increased risk of mortality compared to those patients who do not have all of those findings. There is an evidence of persistent clinical or subclinical congestion that is basically associated with worse outcomes. So what is the evidence that we have? I will start with the medications that are known to improve congestion, and this starts with the loop diuretics. We have the DOSE trial, the evidence that comes with the loop diuretic in patients with acute decompensated heart failure. So DOSE trial was a prospective double-blind randomized trial of about 308 patients presenting with acute decompensated heart failure to receive furosemide either as continuous dose versus bolus dose Q12 hourly. It's a 2x2 factorial design, this trial, and the other part of the trial was to test whether if these patients who are taking low dose of furosemide, which is the home dose of furosemide, versus 2.5 times the oral dose of home dose that they were taking. The purpose of, so what this trial showed was what is the final or the primary endpoint, which was the composite of freedom from congestion at 72 hours. This was non-significant or was no difference whether you employed bolus versus a continuous strategy or whether you chose a low dose versus a high dose strategy. However, in patients with the high dose strategy, there was some improvement in the change in the weight at 72 hours. There was more effective diuresis in the form of net fluid loss in the high dose strategy. And similarly, the change in the NT-proBNP was more reflected in those patients who were on high dose of furosemide. At the end of the trial, at least 25% of the patient in either group showed they had worsening or persistent signs and symptoms of heart failure. So to conclude, whether you employ bolus or continuous infusion strategy, it doesn't make any difference. Although high dose of diuretics, which is 2.5 times your oral dose, was associated with improvement in overall net diuresis, weight loss, and symptom relief. This trial doesn't apply to patients who required either inotropic therapy or required intravenous vasodilators, or who were already on moderate to high doses of diuresis to begin with at baseline. Now, is there any difference of using one form of diuretic compared to the other? So this was a recently published trial called Transform-HF trial, which was a comparison of torsemide, which has a better bioavailability compared to furosemide in the management of acute decompensated heart failure. This trial had both patients with heart failure with reduced and preserved ejection fraction. So the total number of patients were 2,859, which were randomized in 1:1 fashion to receive torsemide versus furosemide. It was conducted in about 60 hospitals across the US. However, this trial also failed to show any benefit of one form of diuretic over the other in the patients who presented with acute decompensation. So it was a negative trial, but it did show that this trial was unfortunately was affected with the COVID. At the same time, there was about 5.4% crossover from between the groups, and at the same time, the diuretic data was unavailable for about 25% of the patients at 1 month and about quarter of patients at 1 year. Whether this will make any difference or not, I don't think so. But the conclusion from this is you can choose any form of diuretic with regards to making any difference in mortality in patients with acute decompensated heart failure. Spironolactone, the effect of spironolactone was looked at about 30-day death in heart failure-related rehospitalization. A secondary analysis from the Post trial showed that those patients who were taking spironolactone had reduction in mortality compared to those patients who were not taking spironolactone. Whether a high dose of spironolactone make any difference compared to those patients who were taking low dose of spironolactone, this was tested in the Athena-HF trial. This was a trial to test high dose of spironolactone of about 100 milligrams once daily compared to placebo among patients who were already admitted with acute decompensated heart failure. And the primary endpoint was to check for what is the baseline change in the NT-proBNP levels at 96 hours or pre-discharge, and it didn't make any difference whether you use a high dose of spironolactone on top of placebo or on top of furosemide versus placebo. And at the same time, the time for first heart failure-related hospitalization or emergency visit for heart failure or death was not difference between the two groups. What about the use of combination of diuretics? So this was another trial which was recently published. This was called the Diuretic trial, safety and efficacy of combination of loop diuretic with the thiazide type diuretic, which is hydrochlorothiazide, in patients with acute decompensated heart failure. So all the patients were on baseline loop diuretic therapy, and these patients were stratified to receive 25 milligrams of hydrochlorothiazide for 5 days, while the other group was receiving placebo. These were all the patients with acute decompensation, and they had prior history of chronic heart failure. 230 patients were randomized to receive 5 doses of oral treatment with hydrochlorothiazide compared to placebo. So the primary endpoint was the win ratio, which was a combination of assessment of changes in the weight from baseline to 96 hours, and to see the assessment for all-cause mortality in 90 days and rehospitalization at 90 days, along with the to look for any adverse events. The addition of hydrochlorothiazide did show that there was a difference in the change in the weight at 96 hours, which was statistically significant. However, at 90 days, there was no difference in the all-cause mortality, all-cause related rehospitalization, and the effective diuresis that was seen came at a cost of impaired renal function and electrolyte imbalance, particularly hypokalemia, which was more commonly seen in the group that received hydrochlorothiazide. Serious adverse events were unremarkable in both the groups. So to conclude, this trial showed that net effective decongestion or diuresis was achieved with a combination of diuretic therapy in the form of thiazide and on top of loop diuretic, albeit at a greater risk for impaired kidney function and hypokalemia. And when we're talking about combo diuretic and the recently published ADVOR trial, which was the use of acetazolamide in acute decompensated heart failure patient presenting with volume overload. So this was another multi-center, though a single country, which was done in Belgium, multi-center trial, double-blind, parallel group, randomized control trial in patients with acute decompensation with clinical signs of congestion in the form of pleural effusion, SITs, or raised JVP, and pedal edema. So these patients were stratified to receive acetazolamide IV on top 500 milligrams on top of the 2.5 times the IV diuresis dose compared to what they were taking at home versus placebo. And the primary endpoint was to see whether successful decongestion was achieved within the 3 days after randomization or not. Patients or group with the acetazolamide showed far more decongestion compared to placebo, as evidenced by the successful decongestion at 3 days. Also, as evident by the congestion scores, which were lower in patients who received acetazolamide, and they had successful decongestion at discharge. It translated to improvement in the secondary endpoints of reducing the hospitalization from heart failure by 1 day, though it was not statistically significant. However, it failed to show that at 3 months, mortality or rehospitalization from heart failure were not significant in both the groups. So to take from ADVOR trial, these were the patients who were not with the first presentation. These were chronic heart failure patients who were on stable doses of oral diuretics, but now presenting with the signs and symptoms of acute decompensation. The patients who basically do merit from the ADVOR trial are those patients who receive higher dose of diuretics and presenting with acute decompensation, not who are diuretic naive, who will probably benefit only from the use of IV diuresis and not as a combination therapy. This trial did not have patients with SGLT2 inhibitor, as at that time, these medications were not generalized to patients with both HFrEF and HFpEF. However, just one point to make that the safety and efficacy of using acetazolamide was safe, and the adverse events were similar in both the groups. Moving on, we have the tolvaptan, and to assess whether the oral tolvaptan was effective in patients hospitalized with worsening heart failure. This was tested in the Everest trial, which was an event-driven, randomized, double-blind, and placebo-controlled trial of about 4,133 patients hospitalized with acute decompensation. The primary endpoint was to see for any change in the cardiovascular mortality or heart failure-related hospitalization. Unfortunately, tolvaptan did not show any improvement in the primary endpoints of all-cause mortality or reduction in the cardiovascular death or hospitalization with heart failure. Whether ultrafiltration improves in patients with the acute decompensation with cardiorenal syndrome. So this was a CARES heart failure trial, which was a multi-center randomized trial of veno-venous ultrafiltration therapy versus a stepped pharmacological approach of diuretic escalation among patients with heart failure, worsening renal function, and evidence of volume overload. So at the primary endpoint to see the mean change from the baseline serum creatinine values at 96 hours. This was worse in patients with ultrafiltration. However, at 30 and 60 days, these were similar events in both the groups. At the same time, patients who were on ultrafiltration had adverse cardiovascular outcomes, and that's why the ultrafiltration is not the part of the initial strategy among patients who present with acute decompensation. The patients who were excluded from this trial were those who required inotropic therapy or intravenous vasodilators. At the same time, the cardiovascular hemodynamics were not measured. So it's unknown whether these patients will actually derive benefit from ultrafiltration or not. And just to conclude with the diuresis, in patients who are using more high salt intake, such as more than 2.8 grams of sodium intake, these patients tend to have worse outcomes who present with acute decompensation, and they are associated with increased mortality. This was an observational study that was published in 2010. So we focused on the first part, which is to achieve adequate decongestion and to minimize the risk of residual volume overload. We will focus on now on how to achieve adequate organ perfusion and what is the data behind that. So when we talk about this, we have the sodium nitroprusside, whether sodium nitroprusside was effective among patients with advanced low output heart failure. This was a study done by Wilfred Mullins in 2008. This study assessed the efficacy of sodium nitroprusside among those patients who presented with low output states, which was defined as a cardiac index of less than 2 liters per minute per meter square. And these medications were titrated to reach the target map of more than 65 and 70 millimeters of mercury on top of the intensive medical therapy. This was a non-randomized study. So what it showed was that the use of sodium nitroprusside did show freedom from all-cause mortality on top of the standard or intensive medical therapy that was used. It was not associated with increased risk or requirement for inotropic support or worsening renal function during the hospitalization. It showed that all-cause mortality was reduced, though it failed to show any improvement with any heart failure-related hospitalization. Low-dose dopamine versus low-dose nesretide was tested in acute decompensated heart failure with renal dysfunction in ROSE-HF trial. This was to test the two independent hypotheses, which is one was whether a low-dose dopamine was effective versus placebo or low-dose nesretide versus placebo. And the primary endpoint was to see whether the cumulative accumulation of urine volume, which is a marker for adequate decongestion at 72 hours, or the change in cystatin C at 72 hours. However, both the therapies did not show any significant difference with regards to the change in the urinary volume cystatin C level. So this was also a multi-center double-blind trial, but unfortunately, neither of those therapies, when added to the standard diuretic therapy, showed any benefit of acute decongestion with acute heart failure and renal dysfunction. Whether the use of milrinone is effective among patients who are stable heart failure presenting with acute decompensation, that is not requiring any inotropic therapy at the point. So this was a prospective, this is an Optime HF trial, prospective randomized a double-blind, placebo-controlled trial of 950 patients admitted with acute exacerbation of systolic heart failure, not requiring the intravenous inotropic therapy. The patients were randomized to receive a 48-hour infusion of milrinone at 0.5 mics per kg per minute, or a saline placebo. And again, this trial also failed to show among patients who had stable heart failure, not requiring the intravenous inotropic therapy, milrinone did not showed any benefit of delaying the hospitalization or rehospitalization, I should say. However, at the same point, milrinone was actually associated with increased risk of adverse events, as manifested by increased risk of myocardial infarction and ventricular or atrial arrhythmias and sustained hypotension. Among the subgroup of the patient, those patients with ischemic heart failure had worse prognosis on patients with receiving milrinone compared to those patients who were non-ischemic cardiomyopathy. Effect of levosimendan was tested as on the short-term clinical course of patients with acute decompensated heart failure in the REVIVE studies. The REVIVE studies showed the patients with, it was two groups, basically, two studies, REVIVE 100 patients, REVIVE 2 600 patients, presenting with acute decompensated heart failure to receive either placebo or IV levosimendan for 24 hours, in addition to the standard treatment. The primary endpoint was to see any change in the clinical status during the first 5 days after randomization. And when we compare that, the patients with levosimendan had better improvement in the clinical status, but this was offset by increased risk of adverse cardiovascular events, particularly among patients whose blood pressure was below 110. So those patients with a blood pressure of 110 and below, they had worse cardiovascular outcomes. Levosimendan was compared with patients with dobutamine in patients with acute decompensated heart failure in the SURVIVE trial. Again, this was a randomized double-blind trial of testing short-term IV infusion of levosimendan or dobutamine to see the long-term survival. These were 1,327 patients hospitalized with acute decompensation, but requiring inotropic support. The primary endpoint was to see all-cause mortality at 180 days, and neither group, whether levosimendan or dobutamine, on top of the requiring inotropic support, failed to show any difference in the all-cause mortality at 180 days. The mean change in the NT-proBNP was more significant, actually, in levosimendan group compared to dobutamine group, but overall, the cardiovascular mortality was not significant in either group at 180 days. So we discussed the first part of achieving adequate decongestion, maintaining end organ perfusion. What about maintaining or restarting guideline-directed medical therapy, which are known to improve prognosis and reduce hospitalization with heart failure? When we talk about that, the first thing is the beta blockers, and multiple trials have clearly shown the beneficial effects of beta blocker therapy in improving not only the morbidity and mortality associated with heart failure. So the optimized heart failure program was the data taken from the Medicare claim database from US. What it showed that among patients who were admitted with acute decompensation with heart failure, those patients whose beta blocker therapy was withdrawn, or those who were eligible for beta blocker therapy but didn't receive any beta blocker therapies, they had increased risk of mortality compared to those patients who were continued on beta blocker therapy or were started on beta blocker therapy. And if you look at the 60 and 90 days post-discharge mortality data, those patients whose beta blocker therapy was withdrawn or not prescribed had far more worse mortality compared to those patients who were eligible for it and received beta blocker therapy. And that's why the guidelines clearly recommend that every effort should be made to continue the guideline-directed medical therapy in patients who are presenting with heart failure decompensation or are requiring hospitalization with decompensation. And the same is the data for ACE inhibitors and ARB. Again, this is the Get With the Guidelines registry, which is another Medicare claims database that clearly shows that at 1 year mortality was high for those patients who were either not started on ACE inhibitors therapy or discontinued, compared to those patients who were eligible and continued or started on the guideline-directed medical therapy, including ACE inhibitors. Both 30-day mortality and 1 year mortality was high for patients among those patients. The use of sacubitril/valsartan in patients with acute decompensated heart failure was tested in the Pioneer-HF trial, which was a trial of 880 HFrEF patients with acute decompensated heart failure. They were supposed to receive sacubitril/valsartan from 24 hours to the 48 hours post, 24 hours of admission to the 48 hours from the discharge and after hemodynamic stabilization. What it showed was the primary endpoint was to assess for the change in the NT-proBNP status from the baseline. Sacubitril/valsartan showed this effect of reducing the NT-proBNP level compared to the enalateral counterpart at no cost of increasing the risk of worsening renal function, hyperkalemia, symptomatic hypotension, and angioedema. So what it shows that the patients who present with acute decompensation, if they are taking sacubitril/valsartan or they are naive of any baseline ACE inhibitors or RASI therapies to short, they can safely be started on sacubitril/valsartan after hemodynamic stabilization. And this received a Class 2B indication in the recent European heart failure guidelines. What about the data for the SGLT2 inhibitors among patients who presented with acute decompensation or with the recent worsening of the heart failure? So we have the data from the Soloist worsening heart failure trial, tested the sotagliflozin among patients with diabetes and recent worsening of heart failure. The primary endpoint was to assess for the efficacy of death from cardiovascular causes and hospitalization or urgent requirement for recent visits with heart failure. Sotagliflozin clearly showed, compared to placebo, a 33% reduction in the primary endpoint, which was primarily manifested by reduction in the heart failure-related hospitalization. The trial was stopped early. Again, this was due to the loss of funding due to COVID-19 infection. However, this was the first large randomized trial among the SGLT2 inhibitors in patients with acute heart failure hospitalization who were stabilized prior to discharge, that the use of SGLT2 inhibitors was safe and effective. Another data that comes from is the use of empagliflozin in patients with acute heart failure, admission with the decompensation with acute heart failure. This is an impulse trial. 530 patients with acute decompensation were randomized to receive 10 milligrams of empagliflozin versus placebo. The primary endpoint was a win ratio, and that is a composite of a change in the body weight, the hemoconcentration, clinical congestion score. But the main point was to look for what is the clinical benefit at 90 days. Empagliflozin clearly showed that there is a reduction in the change in the body weight. On top of, these patients were on top of the diuretic therapy with furosemide, by the way. Empagliflozin as a combination therapy on loop diuretic showed a beneficial effect in reducing the body weight, increasing the hemoconcentration, and improving the clinical congestion score. So this is another study that favored the effect of use of SGLT2 inhibitor being safe in such patients presenting with acute decompensation with heart failure. Though the hard points were not tested in these trials, hard points with regards to mortality or rehospitalization with heart failure. And last but not the least, the recent publication among patients with acute decompensated heart failure was the testing the safety, tolerability, and efficacy of uptitration of guideline-directed medical therapy for acute heart failure, the STRONG-HF trial. This is a multinational open-label randomized trial to compare the high-intensity intervention, which is involving the uptitration of guideline-directed medical therapy for heart failure treatment among patients with presenting with acute heart failure. So those patients presenting with acute decompensated heart failure who were not on full doses of guideline-directed medical therapy, they were stratified to receive a high-intensity or high-intensity intervention versus the usual care, which is left on the discretion of the physician to optimize heart failure therapies. Now, if you look at these orange bars, are basically those with the high intensity group compared to the blue bars, which are the usual care group. The high intensity therapy group among patients with ARNI, ACE or ARB or beta blockers or MRAs, clearly about if you say about the ACE inhibitors or RASI therapies, in short, at 90 days, about more than a three-quarter of patients were able to achieve high-intensity care group arm. Same for the beta blockers and MRAs, which within the usual care, clearly you see the major difference that are not able to achieve full doses of guideline-directed therapies. And the primary endpoint was to compare, was to see the all-cause death or heart failure-related hospitalization at 180 days. And clearly this showed that patients who were more rapidly up-titrated to the guideline-directed heart failure therapy group within the first 2 weeks from the discharge or during the in-hospital stay, they had better outcomes of all-cause death or readmission with heart failure compared to those patients who were left upon to treat as usually. This was also reflected based on the symptomatic improvement. So close follow-up visit with rapid up titration is the way to go to prevent all-cause death and heart failure readmissions at 180 days. As we know that these patients who present with acute decompensated heart failure, they carry a 4 to 6% increased risk of in-hospital mortality, which is transferable at the post-discharge care to about 30% mortality and about 50% mortality at 50% mortality at 5 years. So all efforts should be made to, first of all, prevent the hospitalization with decompensation, identifying the potential precipitants and treat them accordingly, and not to miss any opportunity that may arise during the hospitalization. So we discussed about the two important points. Now we will move to the treatment of comorbidities and avoiding the potential triggers. As we mentioned, the registry data also shows that patients, of course, after presenting with acute coronary syndrome as the first-line therapies, as a first-line issue, these need to be treated first. All the efforts should be made to avoid any precipitants which may increase the risk for acute decompensation with heart failure. When we talk about precipitants and treatment, there is the data from the AFFIRM-AHF trial, which was the utility of ferric carboxymaltose for iron deficiency among patients presenting with acute decompensated heart failure. Another multi-center, double-blind randomized trial of 1,108 patients with acute decompensation and iron deficiency anemia. The primary outcome of a total heart failure-related hospitalization and cardiovascular death. So the trial, to be honest, failed to show a significant benefit with regards to cardiovascular-related death. But when you talk about preventing the heart failure-related hospitalization, the AFFIRM-AHF showed that the utility of ferric carboxymaltose resulted in about 26% reduction in hospitalization with heart failure. And finally, the care about post-discharge care, which basically involves early follow visit after the discharge, which is within the first 1 to 2 weeks to assess for the signs and symptoms of congestion, drug tolerance, and up titration. And as we saw from the data from STRONG-HF, that every effort should be made to up titrate the heart failure therapies as tested in the guidelines. In the transition of care. So to conclude, the discussion was about preventing readmission rates with achieving adequate and successful decongestion to prevent mortality and heart failure-related hospitalization. Every effort should be made to reinitiate the guideline-directed therapies, treat the comorbidities, and to provide an early post-discharge follow-up care. And this is the summary of the diuretics that I discussed about from the dose trial. We can take that either strategy can be applied, whether a bolus versus continuous, there's no difference, but high dose of furosemide was actually associated with net improvement in diuresis, weight loss, and symptom relief. The TRANSFORM-HF trial showed no difference whether you use a torsemide or furosemide with regards to mortality in acute decompensated heart failure. COACH trial, the secondary analysis did show improvement in 30-day mortality with spironolactone. The CARAS-HF trial showed there was worse outcomes with the utility of ultrafiltration in such patients. The ATHENA-HF trial showed there was no benefit of high dose of spironolactone compared to low dose, and actually the high dose was not associated with adverse events, but it didn't translate into improvement in the hard endpoints. Both the Diuretic and Advor trial did show the combination of diuretic therapy does translate into achieving good decongestion, albeit at the risk of adverse events, which is the electrolyte imbalance or kidney impairment, more so seen with the hydrochlorothiazide compared to acetazolamide. And this is the summary for the inodilators and the guideline-directed medical therapy that we discussed just now. And this brings us to the conclusion. Thank you.
Thank you very, very, very much, Dr. Hashmani. It was a really great overview of this very evidence-based management of acute decompensated heart failure. I've learned a lot, really. But it looks that a lot of the trials were negative, and actually, give us more tools for armamentarium to use in acute decompensated failure. And I just want to ask your views and start with the decongestion. So, what's the best strategy? Is it just double the dose of oral diuretics, IV, and how do you practice? How do you implement this? How do you escalate? I mean, I was really interested in the Advor trial and thought maybe something we could talk about in our hospital. But so I just would like to hear what's your take on this.
Yeah, thank you, Dr. Harari, for your comments. So I will divide this question into two parts. So patients who present with a chronic heart failure and who are on a stable dose of diuretics, like 40 milligrams of Lasix, and they are presenting with acutely decompensated heart failure. These are the patients who may benefit from the combo diuretic therapy in the form of using acetazolamide on top of IV furosemide. Those patients, coming to the second group, those patients who are diuretic naive and they are presenting as their first presentation with acute decompensation, who haven't had the exposure to furosemide, they probably will benefit from IV diuresis with the furosemide alone. So this is what I would take it from there. Yeah.
Propom, feel free to got any comment, but
that is interesting. So I think what you absolutely convincingly have shown is that the strong diuresis is key to decongest patients. But I mean, what is it really so new? So the Advor trial, because it's sequential nephron blockade, we used it before, and the data look quite similar to the chlorotic trial with hydrochlorothiazide. So when you have a patient who's really maybe diuretic resistant, so which is a predictor of poor outcome, what do you think of combining them? Maybe you have the loop diuretic and you add maybe 2 or 3, like SGLT2 inhibitors, the hydrochlorothiazide, and maybe the other drug also, carboanhydrase inhibition. Do you think it works?
Well, in patients with diuretic resistance, combination diuretic therapy definitely would work. But the point is what to choose. Yani, there are 3 diuretics we discussed. On top of the furosemide, the Advor trial didn't have patients on SGLT2 inhibitors. Similarly, the using of SGLT2 inhibitor on top of furosemide would benefit. The use of acetazolamide in the Advor trial didn't translate into adverse events or electrolyte imbalance compared to the chlorotic trial, where they did show the adequate decongestion at the cost of worsening renal failure and severe hypokalemia, which was statistically significant. So in my opinion, these patients who present with diuretic resistance probably will get benefit from a combination diuretic dose with acetazolamide on top of 2.5 times the home dose of oral diuretic therapy.
Yeah. Yeah. So maybe it's just selecting the patient that you would start with combo, because a lot of time we just wait 2-3 days, escalating dose, and then respond. Then you add the thiazide diuretic or the metalizone, whatever. So maybe, as you said, the one that already on a big dose at home, non-established heart failure, comorbidities, maybe those are the ones who benefit from upfront combination. Maybe. My other question, just you probably didn't touch on, is use of vasodilators in acute decompensated heart failure. Is there a role? Is it just only for the hypertensive, or which one do you use? You mentioned the nitroprusside.
Yeah, so the sodium nitroprusside was used in patients who had low output heart failure. So those with a cardiac index of less than 2.2 and were otherwise on stable heart failure medications. So those patients did derive benefit the addition of sodium nitroprusside, translating to the fact that at discharge these patients did receive oral nitrates and what it translated was the significant symptomatic improvement in those patients. With regards to the utility of the other inodilator, which is milrinone, among patients with stable heart failure with normal blood pressures, as we discussed, it actually failed to show any benefit on top of the heart failure therapies. In addition, actually, it was associated with worse clinical outcomes and adverse cardiovascular events.
Yeah. What about the use of? We still use, a lot of people do use that dobutamine for acute deficit heart failure with lowish blood pressure and some even even chronic use. I mean, we still use it. I mean, the evidence doesn't back it up. What's your comment on this?
Yeah, so as I presented the comparison of the data on the use of dobutamine or dopamine, actually, it was low-dose dopamine and low dose of nesretide. Again, there is no benefit if your focus is on to get adequate decongestion or in the form of improving renal perfusion. The trial clearly showed that there was no benefit of employing the strategy of either using low-dose dopamine versus low-dose nesretide. So based on these data, clearly it doesn't show any benefit of using one strategy over the other. Clearly, if the patients are in shock state or those with cardiovascular hemodynamics clearly showing that they need a more inotropy therapy or inodilator therapy, that is different. But among patients with stable low blood pressures, and targeting renal perfusions and giving low-dose dopamine or per se low-dose dobutamine will not have a major impact based on the study that I mentioned.
Prof. Pom, do you have any comment on the use of vasodilator inotropes before we move on? Or any other questions?
Yeah, of course, the inotropes. There is, by the way, for the use of inotropes to glutamine and also the PD inhibitors, a huge variability among regions. So when we have discussions in the ESC during the guidelines, then some people say we never use it, like the British, and in Germany they are sometimes used. So the old guideline had the recommendation if the blood pressure is below 90 and really have signs of hypoperfusion and a low cardiac output, you mean you pale and wet and dry and cold periphery, then it makes sense to use them. But it comes at the cost of a potential adverse effects on outcomes. You kill a couple of myocytes, and I don't think you are better afterwards than before. So it's a life-threatening indication. Honestly, we are doing that, but these are really desperate cases. Yeah.
Okay. Thanks a lot, Rashmi. I really appreciate it. We learned a lot. Very nice, very comprehensive overview and discussion. So we'll move on now to the second part. Our really guest speaker is Prof. Michael Bohn, who doesn't really need introduction. He's the director of the cardiology and internal medicine at the University of Saarland in Germany. He is a board member of the Heart Failure Association, European Society of Cardiology. He's been a principal investigator or a steering committee of most heart failure that we know recently. Previously, I know the paradigm have reduced and preserved DABA heart failure. He is written more than 350 version articles, chapters in books, and he's a reviewer in most famous scientific journals. He's going to take us over the heart failure management across the all ejection fraction And we look forward to, it's going to be just open discussion, and I'll be grateful for Dr. Hashmani also contribute and all the attendees. Rahman, floor is yours.
Thank you very much for the nice introduction. So I switch a little bit gears here now, and I was asked to discuss heart failure management across all ejection fractions, but I will also a little bit stay with the acute decompensation and what are we doing afterwards. So first of all, the problem with the different ejection fraction is, as you know, that heart failure is derived from risk factors. And if there is coronary thrombosis and myocardial infarction, there is eccentric remodeling, and the consequence is heart failure with reduced ejection fraction. So that, I think, is quite clear. Therefore, more males have it. It is associated with age. It's associated with, of course, decompensation, but also sudden death and reinfarction. So this is the one form of cardiac failure. And of course, this is maybe something which is a target for inotropes, among other drugs. And then there is, of course, another form, which is concentric hypertrophy in patients, particularly who do not develop myocardial infarction. So they have more myocardial infarction than these patients, and these patients have a long-standing history of hypertension. There are genetic backgrounds, there are specific cardiomyopathies, as also in eccentric forms, such as post-myocarditis, MI, or congenital cardiomyopathies, but here you have hypertrophic cardiomyopathy. And the most prominent prevalent cause is, of course, long-standing hypertension. There is a change in arterioventricular coupling, and therefore these hearts look completely different. However, the clinical picture, when they are decompensated with congestion, when they are decompensated with overload, volume overload, and when they are decompensated because there are certain trigger mechanisms, such as tachyarrhythmias, then they look quite similar, and that requires, of course, diagnostics. So these are the two forms, concentric and eccentric heart failure with reduced ejection fraction, preserved ejection fraction, and this term could change and maybe change to normal ejection fraction, as the term preserved ejection fraction comes from the times of the sham trial, where this was defined as an ejection fraction of greater than 40. But in the guidelines of 2016, we had these two forms, but in order to better separate between those, the guideline authors defined a group which is above 40 and below 50, so 41 to 40, 50, 49, where they said this is mid-range ejection fraction. This was done in order to better separate between the two other groups, as it was completely not known whether this is a continuum or whether these are completely different groups. So therefore, at that point of time, and that is the definition of the old guidelines, 40 to 49 was defined mid-range, which does not tell you of whether these hearts are sick or not. So then the guideline changed, the guideline of 2021, and it was named heart failure with mildly reduced ejection fraction. And I will tell you in a couple of minutes why this was changed. And here patients with signs and symptoms, they have heart failure and an ejection fraction of 41 to 49, while in the old guidelines, there was a demand to do further diagnostic measures such as natriuretic peptide or to prove diastolic dysfunction or structural heart disease. Now that is what we have. This was refined by a universal definition among many different scientific societies, Canadians, Americans, Europeans. And what you can say that indeed patients with reduced ejection fraction was defined mildly reduced and preserved, and also a group which is important when patients are going to increase with their ejection fraction by 10%. And in addition, they change the group, for instance, from reduced to mildly or even to preserved ejection fraction. Then we have this group of patients with improved ejection fraction. Now, what are the treatments? First of all, let me talk about the recommendations we gave in the last Heart Failure Guidelines 2021. And this is related to heart failure with reduced ejection fraction, as the new data with preserved ejection fraction were not available at that point of time. And what you can see that, and this is a strategic change of the guidelines, all the recommendations and interventions were recommended to be started immediately and together, not a stepwise increase which takes time and might also put patient at risk for further events, but it should be started with all the drugs which are modifying outcome, ARNI, beta blockers, MRA, and dapagliflozin. Empagliflozin, who are the new drugs which have been introduced here. But in order to prevent acute decompensation in every patient who have signs and symptoms of fluid retention, even if mild, the diuretics and loop diuretics should be given. And then one can advance to subgroups which might have an indication for other drugs like vericiguat or ivabradine, or to mitral clip, ICD, whatever. But we will talk about here the drug treatment. Now, if this is true, one would suggest that postponing drug treatments add another risk of decompensation and death. And this indeed was studied in 2016 after the old guidelines, withholding one drug for 1 year, and that can take 1 year, adds 3% death rate. Doing one drug plus a beta blocker, then you are already at an excess death rate of 7.8%. And by postponing for 1 year 3 drugs, you end up with 12.2% of additional deaths. And that is a huge effect of not providing these therapies. And that means that is something which you indeed is much greater and more prominent than the beneficial effect of most of the drugs we know. So therefore, this simple strategic change, the hope is that we will indeed save a lot of events by just starting with all of them. So time to therapy initiation is associated when prolonged with increased number of mortality. But what about now the new trials and the new data? This is heart failure with reduced ejection fraction, and I brought you here the DAPA-HF trial and the EMPEROR reduced trial. You can see two drugs. What they have in common is that they have very similar risk reduction, 26 and 25%. The curves separate early, so there is an early onset of treatment effect. I will go into detail later on. And then, of course, we have the benefit in chronic heart failure. So I stop here because you all know the data, which is well known in heart failure with reduced ejection fraction. Now, what about the more tricky groups, which is heart failure with mildly or preserved ejection fraction? So first of all, mildly reduced ejection fraction. You've seen that many trials have been neutral, and these are indeed the red ones. So they cross here the line of neutrality, and they all miss the primary endpoint. Comparing that to trials with heart failure with reduced ejection fraction, you can see that these trials don't do so, and they are positive. But you can also see that there is a big overlap, indicating that potentially some of the subgroups might have some effects, but they needed to be characterized and figured out. And that was done by the investigators of the Paradigm and Paragon studies. So they took together the two trials, one done in heart failure with preserved ejection fraction, Paragon, and one with reduced ejection, Paradigm. They imputed a control group from the sham trial, and then they were able to look at the treatment effect of sacubitril valsartan across the whole spectrum of ejection fractions. And what you can see that approximately at 55%, there was a treatment effect and the trial was positive, indicating that patients who have so-called mildly reduced ejection fractions and heart failure, they do benefit from this treatment. So what was not recommended before has now proven to be effective concerning sacubitril valsartan. And extending these findings, and this is what you just saw a minute ago, sacubitril valsartan was also observed with spironolactone. Here is the TopCat trial, which started to recruit patients from 45 and above, but in the group until 50-55, there was this treatment effect. You can see a signal for beta blockers. This is a senior trial at this point, because senior randomized elderly patients up to 50% ejection fraction. And you can see here the sham trial, which obviously has also the same effect. So therefore, we have these treatment effects in the patients with mildly reduced ejection fraction, and that became a treatment recommendation to be, because it was put together from several subtypes and secondary analyses, and it's a C recommendation because all these evidence, the totality of evidence, was judged by experts, and there is no dedicated trial. So just for the formal description of evidence, it should be, or it could only be a class 2B/C recommendation. But what means only? It's not so strict, because indeed this 2B's 1B, 1A describes principally the way how one could come to a treatment recommendation. Now what you've seen are the treatment effects of these single drugs. And also preventing decompensation means that the whole neuroendocrine axis should be blocked, heart rate should be controlled, and maybe also cardiometabolic factors should be improved. And there was one analysis, quite interesting, showing that when the treatment combinations were looked at, adding an MRA, adding SGLT2, and putting that all together, then you can see at an ejection fraction on the upper line here, 45 to 54, a reduction of cardiovascular death and heart failure hospitalization by 50%. This finding was also robust when one looks at cardiovascular death, what is very interesting, and also, of course, heart failure hospitalization. Yeah, you can see here the number. So coming from different angles with different mechanisms apparently makes sense. And this also covers higher ejection fractions. And this is much in line with the combination therapy we utilize in heart failure. And apparently that works also in heart failure with mildly reduced ejection fraction. Now, what shall we do when a patient is improving? For instance, by 10 points from heart failure with reduced ejection fraction, or even to heart failure with preserved or recovered ejection fraction. Then the group is called heart failure with improved ejection fraction. Do we have any data of SGLT2 inhibitors? This group, in order not to confound the results, were excluded in EMPEROR reduced. But DELIVER, which is a second HFpEF trial, included these patients. So if there was a second ejection fraction which was low, and then the patient included and went up to values above 40, then they were recruited. And you can see this paper just very recently published in Nature Medicine. You can see that the effect is maintained. So these are only patients who have had a heart failure with improved ejection fraction, and again, the effect is robust. So the guidelines are in agreement of treating these patients, because when a heart ejection fraction is improved and you withdraw the drugs, then there is, according to a study called TREAD, there is danger that 50% of the patients again deteriorate, and you never know whether you have a second chance to bring them back to a normal ejection fraction. But if patients like this present and they have the criteria to be incorporated in one of these trials, they benefit. So therefore, improved ejection fraction is another treatment indication. So what about preserved ejection fraction? And this is really a nightmare. You can see here one of the trials with irbesartan, I-preserve, and they looked at ejection fractions above 40, and you can see this is clearly neutral. And there are good reasons to look at irbesartan because it has anti-hypertrophic effect. It reduces fibrosis in animal models and disease models, and it protects, of course, also the kidney. But you can see no effect on pre-specified cardiovascular hospitalizations or deaths. So we have many trials who failed. ACE inhibitors, ARBs, beta blockers, ivabradine, that was the EDIFY trial. And we have these studies missing the primary endpoint, but have strong signals, sacubitril, valsartan, and spironolactone. So now, why was the SGLT2 inhibitor investigated? And this is quite interesting, and I brought you here data from different trials in heart failure with reduced ejection fraction and preserved ejection fraction. And what is depicted here is the event rate per 1,000 patient years. And if you please look at the blue column here, you can see patients with diabetes with a history of hypertension from the EMPEROR outcome trial, and they were on placebo. They were not treated. So you can see the event rate is similar to HFpEF trials compared to HFrEF trials. And as these patients benefited, the conclusion was made that these are most likely patients with HFpEF. And as they benefited in the EMPEROR outcome trial, the risk was taken to do a trial in patients with heart failure and preserved ejection fraction with empagliflozin. So this is the whole trial program. Patients were either assigned to a group with a higher ejection fraction or a lower one, and all in the same centers under the same leadership with the same endpoint. So a heart failure patient came by in the center, and then he went either into the box of reduced or into the box of preserved ejection fraction, and then all the endpoints were taken. So these are the results. Clearly, the first trial, which showed a robust finding for heart failure with preserved ejection fraction, 21% risk reduction. Again, the curve starts quite early, and the number needed to treat was approximately 30. So here you can see that indeed this is a clearly positive trial. There is no interaction with ejection fraction whatsoever. There is one outlier here, but when it comes to higher ejection fractions above 70, the effect is back to normal, indicating that there is no interaction at all. And this is also reflected here by the neutral p-value, so there is no difference. And then luckily we have a second trial, which is the DELIVER trial with dapagliflozin that you can see that looks quite similar. Again, number needed to treat 32, p-value very robust, starting early the effects, the separation of the curve. It looks almost the same to EMPEROR preserved, but also to the reduced trial, so that is also the same. And in accordance with this, you can see that the treatment effect is in parallel below the line of neutrality, indicating that there is no interaction with the ejection fraction at baseline. Same in DELIVER and EMPEROR. So these trials were compared because the question for the guideline committee will be, can we give a class recommendation of both of the agents? And you can see across the whole spectrum of ejection fraction, the treatment effect was exactly the same in patients with truly preserved ejection fraction up to greater than 60, that is this boxes here, there is a robust effect on outcomes. So therefore, no difference between the drugs, no difference across the spectrum of ejection fraction. Now, when this was published in the EST, we did not have the data. The guideline was just presented before EMPEROR preserved was reported. But the Americans, they did the guideline a little bit later, and here you can see on the left-hand side, mildly reduced ejection fraction, on the right-hand side, preserved ejection fraction, and the recommendation are the same. SGLT2 inhibitors are recommended for patients with mildly reduced and preserved ejection fraction. That is a class 2A recommendation because these patients, of course, there was just one trial. And the other recommendation is RNase inhibitors, MRAs, and beta blockers is a 2B recommendation, exactly as in the European guidelines, indicating that we have now an armamentarium for patients with higher ejection fractions. Now, what is new? We try to do them all together. And one of the reasons to try to do them all together is an early treatment onset. 28 days for DAPA in reduced, and 12 days already in reduced for EMPEROR. But you might ask the question, what happens with preserved? Exactly the same. 18 days until the treatment effect. Here you can see the study days, so days after randomization, the effect becomes statistically significant after 80 days and 30 days with dapagliflozin, indicating that when a patient is presented, the treatment should be started quite early and immediately. And this slide you have seen before by the previous speaker, we are particularly concerned after a decompensation about these patients who just are discharged from the hospital. They have in the first months to 3 months a very high rehospitalization rate. And this rate, of course, is predictive of dying later. And so it's very poorly treated, but it's also a high risk group. So the question is, how can we deal with this? And one of the possibilities is to start after recommendation in the hospital. And you heard many data about beta blockers and others that this would make sense. However, we have one dedicated trial, and you also, this was mentioned in the previous talk. It's a trial which has a similar design as the pioneer trial with sacubitril valsartan. Patients were randomized in the hospital when they were recompensated, very close to a recompensation, only 12 hours after the last application of IV vasodilators and 24 hours after the last application of Inotropes. So what this investigators did, they make a hierarchy of the endpoints. Most important is death, then hospitalization, and then quality of life, and did a win ratio. A win ratio means every patient who was treated was compared to one patient on placebo. That is shown here. So from this 400 patients you can generate, so it's 190 against 190, you can generate more than 40,000 base pairs. This is used to increase statistical power and to find something like a net clinical benefit. So if a patient dies and the other one is still alive, then the one alive has won. The same for hospitalization. And then you go in that order through all the endpoints. And then finally, you divide the number of wins in the treatment group with a placebo group. And then you have this likelihood of having one more. So the win ratio in this data set in patients after an acute compensation, and this was a mixed population with heart failure with preserved and reduced ejection fraction. So it accounts for both of them, was 36%. So there is a 36% higher likelihood not to die, not to go into the hospital, and to improve his quality of life, which is quite a significant finding depicted here. And below you can see that all the components go into the right direction, although of course they are underpowered. That is the reason why the win ratio was chosen here. So there is another point now where the new updated guidelines will make a point of, and that is the treatment of acute decompensated patients shortly after recompensation. How to do that? When the guideline was published, starting on 4 drugs, people were very critical. And one way, among others, which are recommended here by the European Heart Failure Association, and here together with some of the American colleagues, you can see that patients should be phenotyped according to heart rate, blood pressure, atrial fibrillation, yes or no, and also kidney dysfunction. And here is a problem. These are the red bars. Poor treatment, high outcome rate in and shortly after recompensation. So the goal is to make this area more green. So starting early with therapies, maybe by utilizing these patients. So when a patient, of course, has a low blood pressure and a high heart rate, then it appears advisable to start with a beta blocker and maybe ivabradine, because the risk is high in patients with high heart rate, and beta blockers and ivabradine do not affect blood pressure so much. Ivabradine not at all, and beta blockers slightly. So it would not be a good idea to start with a high dose of an ARNI. SGLT2 inhibition always works because it's one-step titration with no or only minor effects depending on baseline blood pressure and on blood pressure. So therefore, this can be done. You can start also with eplerenone which has less blood pressure reducing effects than spironolactone. And along these lines, according to these profiles, you can phenotype all the patients, and at the end of the day, you have given drugs with a high likelihood of a big treatment effect and a high likelihood of good tolerability. And you can also double check that you haven't forgotten anything. So if you do that, then you can expect really a significant gain of lifetime for patients with heart failure. So taken together, diabetes trials help to discover SGLT2 inhibitors as heart failure drugs. There is no interaction with ejection fraction. There is a class 1 recommendation for reduced ejection fraction. There might be one later because the guidelines are updated and we now have the trials, 2 trials, and meta-analysis of both of the drugs. So this might change in mildly reduced and preserved ejection fraction. We have in most conditions no interaction with risk conditions such as low blood pressure, aging, frailty, CKD. So there is a one-step application, no up-titration with 10 milligrams. Rapid implementation of all of the drugs appear to be of particular importance, and it should be done in the hospital and at every visit in the outpatient after rehospitalization. Drugs should be controlled and up-titrated, and this, of course, you have seen in the previous talk, is evidenced by the strong AF study. So we have now an update of guidelines which will appear during the next weeks. And it is really a manuscript which is a good read because it will address post-discharge, post-acute heart failure. It will address also iron therapy, SGLT2 inhibitors, and also the strategy of implementation and adjusting therapy at every visit thereafter. So forced up titration of this. Thank you very much for your attention. You are unmuted, I think.
I'm sorry. Okay, yeah. Okay, thank you. Thank you very much. Much appreciated. Really great. I'll kick off. Dr. Hashmani, please feel free to just interrupt. And I always felt uncomfortable with this middle range, mildly reduced. And I like what you mentioned at the beginning. Heart failure with reduced ejection fraction and heart failure with normal ejection fraction. I think that's probably just makes to me more sense. And if and that, just talking about guideline directly therapy, I think the most important message is start early and titrate quickly. And it seems to me for SGLT2 inhibitor for all, what's called it, ARNI, MRA for those up to subnormal ejection fraction. Probably beta blocker only for heart failure with reduced ejection fraction. And you mentioned that there will be a new updated guidelines European probably this year. What do you feel about is this going to change to include something like this to simplify even the classification and the management for POM?
Yeah, we have already, that is, the process is that it has been voted upon. Some of the results are there. I know the manuscript, but I cannot talk about it, as you can imagine. But of course, the topics included is a new recommendation of SGLT2, and I've shown you the data. You can imagine in which direction that goes. There will be a new recommendation of IV iron, because we now also have a second trial, the Iron Man study. That is another point. We will address, of course, the strong HF study, which has been discussed by Dr. Hashmani before. Because that is now a trial for a strategy which is good, and also maybe the definitions. But around calling it normal when a patient is heart failure is a little bit difficult for some people. So the output is not normal. So why should we name it normal ejection fraction? So I think this is, I don't know the results of the voting, but this I think is heavily discussed. We will see what the decision at the end of the day will be.
Yeah, interesting. If I can carry on, can I ask you about this heart failure with improved ejection fraction? I think again, it's not one phenotype. It's so different. So some people find it difficult to say that you have to keep, for example, the 4 pillars on somebody who has, say, tachycardiomyopathy, or maybe peripartum must normalize completely, compared to somebody who had ischemic cardiomyopathy, just improved with revasc and bit gone to 45. Do you think, what's your comment? They are not one group, are they?
Yeah, your question is absolutely right and well taken. So there was one study, the TREAD-HF study, that was done in non-ischemic cardiomyopathy. And I think we all agree that these are patients who do respond quite well. When you then go off the drug, and what they did in the design of the trial, they have withdrawn all drugs. Yeah, it was without SGLT2, but all drugs were withdrawn, and then 50% are deteriorating. So the conclusion is one should better maintain the drug. So that is what we know. What we do not know is whether we need maximal doses, whether we need 4 or maybe 2, maybe 1. Or the other thing is whether there are specific forms of cardiomyopathy which have a high spontaneous rate of resolution, which are not prone to come back. This could be peripartal cardiomyopathy, it could be tachycardiomyopathy, however, then you need, of course, heart rate control. It could be forms of myocarditis, which in part might have been included in this. So there are lots of gaps in knowledge, absolutely correct, but all the guidelines that have IMREF recommend maintaining therapies. I think the key is when a patient then is tolerating it well, okay, you can keep it. If it's not well tolerated, you might reduce it. But the important point is to see the patients and indeed to have control appointments to see whether he is deteriorating.
Yeah. If I can just take this back to the SGLT2 inhibitors. I mean, the EMBA-REG, which you clearly show that actually it showed that more or less it prevents heart failure. I mean, if you give it to diabetics with high risk, they don't go into heart failure. Is there a case for high people, non-diabetic, high risk of heart failure? Don't know how you define that. That you can give them SGLT2 inhibitors. No, you need a trial to prevent heart failure.
Obviously, there is no trial, but you please, patients at risk to getting heart failure, for instance, have impaired kidney function. Yeah. And therefore, when the eGFR is below 60, then we have the EMPA kidney study and we have the DAPA-CKD study. And interestingly, they benefit from their kidney outcomes. That is what you would expect, but also from heart failure hospitalization.
Yes.
So the patients who have kidney disease, they are very prone to develop heart failure, and maybe this could be something, or this could be the group you mentioned, patients without heart failure but at high risk for heart failure, and in these patients it works, and that was also independent of diabetes. Yeah.
Yeah, it was. My other comment just for SGLT2 inhibitors. Is it a class effect? And this is a question you get asked all the time. Is it that? Is it this? Does it matter?
Yeah, that is, you find some of the components of the endpoints positive or numerically reduced and not quite significant. And that is the reason why these meta-analyses were done. Yeah, you have these trials, and now the recommendation can be and should be SGLT2 inhibitors are good, but if there is a difference, one would be more cautious to give such a recommendation. And when you put the data together in the meta-analysis, you increase the number of events, and therefore these findings become statistically more robust. The examples are very simple. So DAPA-HF, reduced ejection fraction, dapagliflozin did not show an improvement of renal outcomes, not decline of eGFR, that was exactly the same, but they did not reduce dialysis, for instance. And the reason was they started at 10 milliliters per minute more eGFR. So the time was not sufficient to bring them into dialysis. So it could not be shown by this. The other example is empagliflozin had no significant effect on cardiovascular death. It was a rare endpoint, but DAPA had 1,000 patients more in the trial. So there is a better statistical power for the rare endpoint when you have more patients. Therefore, it became positive. And then is a reason to do two statistics, comparing the results of the trials, whether significant or not, and see whether there is significant difference. And that was not the case. So we have no reason, also not pharmacologically, to believe that between DAPA and EMPA there is any difference. So therefore, it should be and will be a class recommendation.
Perfect. Dr. Hashmani, do you have any comment? I was going to ask you a question myself.
Fantastic presentation from Dr. Boom, and just learning from what he's teaching us today.
We'll learn from you as well. Hashmani, this is something was mentioned by Prof. Boom, and I was going to ask you, in your presentation, use of ivabradine during hospitalization in combination with beta blockers, something we do not infrequently. Do you have any comment on that? Just talking about acute decompensated heart failure.
Well, as far as I'm aware, I think there is no such trial directly looking at the use of ivabradine in patients with acute decompensated heart failure. But as Dr. Boom mentioned about the drug layering effect, patients with low blood pressures, with high heart rate, they may get benefit from ivabradine. But as far as I know, I don't think that there is any trial directly looking at ivabradine in patients with acute decompensated heart failure.
Yeah, that's right, and that is really a pity. It is really a pity because that was never been done. It was not done by the manufacturer. There are trials in patients who are very unstable. So, the more advanced heart failure where they combined carvedilol with ivabradine, and ivabradine facilitates the uptitration with carvedilol, and after 3 months, the ejection fraction was better. But you are completely right, no trial, but it is really a pity that we do not have data here. Yeah.
Okay, I think we probably will draw this to a conclusion. I'd like to thank you, Dr. Hashmani, for stepping in and for giving us a great overview of the evidence behind acute decompensated heart failure. It was really very refreshing to me, and I'm sure a lot to learn from it. Prof. Boom, thank you. I know you had a very tiring journey throughout the country, in and out of the country in the last 24 hours. And a lot happened to you, and we've learned from you. Really, I've learned, at least knew you, I met you, and that's really an honor for me. And I appreciate you staying up late till 1 or 2 hours before you fly. That's very kind of you, and look forward to meeting you in the future. Thanks for the audience. I hope this was some benefit to you, some refreshment, and we'll see you in the next webinar in a few months' time. Thank you.
Thank you.
Thank you very much.
Thank you.